I'm Dr. Atul Limaye. I'm an interventional cardiologist at Fortis Hospital, Mulund. I'm also involved in the heart failure and transplantation program at my hospital. The topic for discussion today is advanced heart failure, the need for collaboration across specialties. And I would like to introduce my esteemed guests this morning. To my left is Dr. Narsimhan. He needs no introduction. He is a cardiologist, an eminent cardiologist at Care Hospital, Hyderabad, very active in electrophysiology, represents the field in national and international meetings. To his left is Dr. C.S. Hiremath. He is the head of the Department of Cardiovascular and Thoracic Surgery at Sri Satya Sai Institute at Bangalore. He is also the secretary of the Indian Association of Cardiothoracic and Vascular Surgeons. Since we are dealing with a complex group of patients, typically New York Heart Association class 3 or 4 heart failure patients, it is becoming increasingly important to be able to collaborate among different specialties in order to choose the right therapy, particularly as we are dealing with issues of mechanical circulatory devices and heart transplant decisions. Before we get to that, I wanted to address the issues of rhythm management strategies, and I want to address this to Dr. Narsimhan. I sometimes struggle with the following scenario, and I'll lay it out for you. A 50-year-old, he has advanced heart failure. You're seeing him in the clinic setting. He has severely impaired LV function, let's say 15% or so, dilated akinetic left ventricle, non-ischemic cardiomyopathy. But surprisingly, the RV is okay, and he does not yet have any significant valvular abnormalities other than maybe just mild mitral regurgitation. The underlying rhythm is atrial fibrillation with a wide QRS of 150 milliseconds and a left bundle branch morphology. He's had 2 episodes of hospitalization in 12 months, but now he's reasonably stable and seeing you in your clinic. What are your thoughts of trying rhythm control in someone like this with, say, amiodarone and cardioversion, and the thoughts of CRTD versus CRTP versus listing this patient for transplant? So really 2 separate questions. The first is AF management, data for sinus versus atrial fibrillation in end-stage heart failure. And the second is a choice between CRTP and CRTD. Are you now less enthusiastic about a defibrillator given the Danish trial and its equipoise in terms of efficacy in non-ischemic cardiomyopathy? And then in a resource-limited setting such as ours, would you then do both, do AF management and do a CRTP and then list her for transplant? Or would you say, I will forego these 2 procedures and then directly list that patient for transplant?
Thank you very much. This is a very common patient that we see in practice. Atrial fibrillation and heart failure coexist. So when you see a patient with atrial fibrillation, certain things tell you whether this atrial fibrillation is chronic or acute. One is the duration of symptoms. Second is the size of the left atrium. And third is how much of wall thinning is there in the left ventricle. So if you have a ventricle which doesn't move much, has a low EF, but the wall thickness is preserved, then we feel that especially you need to ask the echocardiographer to see in long cycles, short long cycles, whether the myocardial thickening is happening. So that indicates there is a myocardial reserve in this patient, even though the EF is very low because of atrial fibrillation and left bundle branch block. So if you have a person with a left atrium not very large, say less than 4 centimeters, wall thickness of 9 or 10 millimeter, it's hypocontractile but not scarred, then I would go all the way out to kind of restore sinus rhythm and give CRT. There is increasing evidence that CRT in heart failure with left bundle branch block works very well if the AV node is ablated. So if you give a CRT to this person without ablating the AV node, you will wrongly conclude that the CRT is ineffective. You need to take care of the AV node so that there is a synchronous activation by the biventricular pacing rather than leaving intrinsic conduction to come through.
So in terms of a CRT device, you're talking about ablating the AV node. Would you routinely suggest doing that, or would you see on a device check what percentage of the time are they BIV paced? Does that have is that a factor as well? Because frequently we will see that when you do a device check, they are 95, 96, 98% BIV paced, and sometimes they're still not responding.
Exactly. This is a very important question. This is a common misconception. When the device indicates it's BIV paced, all that the device knows is it has emitted a pacing impulse, but it does not know whether there was a simultaneous activation of RV and LV. So for this to happen, very often there will be a fusion activation on top of an existing QRS. Remember, the sensing lead in a BIV is the RV. You have a person with a left bundle branch block, and the intrinsic conduction is coming through the right bundle. So in this patient, the moment you sense something you are going to pace, it is never the same as you have a simultaneous contraction. So you need to do a Holter and see whether there is subtle morphology changes suggestive of fusion. If that is happening, you should still go ahead and get rid of the AV nodal conduction.
And then what are your thoughts then on patients who do not have atrial fibrillation, but they have intermittent complete heart block? And then the thought is that if you just put an RV lead, they will tend to pace more, and therefore you put in a CRT device because of complete heart block. Do these patients fare as well as someone who does not have complete heart block for whom you are putting a BIV device?
Yeah, the thing is, it's a bit of an overkill of implanting CRT for every person with an AV block. There is increasing evidence to suggest that we don't understand this AV block very well. We think all AV blocks are the same. If you take a patient who has deteriorated following a pacing, they have certain mutations called as junctophyllin mutations, or they have a disease which has affected the AV node but is going to progress and cause myocardial dysfunction. So our understanding is improving here. We have slowly moved to doing a physiological pacing in these patients, directly capturing the His bundle or doing an outflow tract pacing, which significantly reduces the chance of these patients going to pacing induced LV dysfunction. So if you do this, your chances of developing a pacing induced LV dysfunction is very minimal.
And as a non-electrophysiologist, is it true that His bundle pacing takes up more battery life and therefore you need to perhaps replace the battery faster?
Yes, the battery drain is slightly higher than a regular pacemaker, and therefore when you choose a pacemaker, you need to go for the newer generation of batteries which have longer longevity of about 9 to 10 years. And you need to ensure there is a His bundle injury current when you put in, so that the pacing threshold remains low.
Let me take away the left bundle branch morphology, let me take away interventricular conduction delay, let me take away the heart block situation, and let me just ask you about plain old atrial fibrillation. And do you try to restore and we are talking plain old atrial fibrillation, end stage heart failure. Are you trying to restore them to sinus rhythm with several tries of either antiarrhythmics or AF ablation or what have you? Or are you trying strictly a rate control strategy?
Again, this depends on the chronicity of the disease and in what stage you are seeing. You have a person with an old MI 20 years ago. He was in class 2, deteriorates to class 3 and then becomes class 4 after 20 years, develops atrial fibrillation. This patient is at the end of the road. On the other hand, if you have a person who was doing well, class 1 in heart failure, EF of 40%, suddenly they come in class 4. This is very typically seen in patients with hypertrophic cardiomyopathy. In these patients, we take all the effort to restore sinus rhythm. Initially with drug therapy and cardioversion, and if it at the end of restoring sinus rhythm, you find there is a reasonable amount of LV dysfunction that is corrected, we take them up for ablation to give a definitive therapy.
And that seems to also work for tachyarrhythmia-induced cardiomyopathy,
That's right.
where restoration of sinus rhythm seems to be much, much better than just rate control.
That's right.
Thank you very much, Dr. Narsimhan.
Thank
Those
you.
are very, very important electrophysiology issues which you very expertly and deftly delineated. My next question is for Dr. Hiremath. I am curious about your decision pathway with regards to choice of the various mechanical circulatory support devices that we now have available. So let me present a scenario of just 10 days back. 50-year-old patient, large anterior wall MI in cardiogenic shock. We take him emergently to the cath lab. The LAD is opened in the cath lab. Flow is restored, TIMI3 flow. He leaves the cath lab with a balloon pump, despite all the negative trials of a balloon pump, and on moderate doses of vasopressors, say about 8 or 10 mils per minute of norepinephrine. Within the next several hours, as he is in the CCU, it becomes apparent that he is not doing well. His pressure requirement is increasing. His lactate comes back very high. He is now intubated. And it becomes apparent that despite opening his artery, he is going to need some sort of a mechanical circulatory support device. How do you decide the level of support? By which I mean, when do you decide impella versus when do you decide peripheral VA ECMO? And then how do you factor in when to put in a central VA ECMO, which will require a thoracotomy? And is cost and availability of these devices a factor in your decision making?
Yeah, in fact, it's a very good question. The main factor we would look at is already the balloon is in place in this patient, and immediately after shifting to ICU, we do have a crisis wherein the patient has gone into a cardiogenic shock-like picture. Now, as you told, it depends on the availability of the resources what we have for the assisted mechanical supports. And if resources are available, in this case, if lungs are not compromised, I would still take him back to the cath lab, and I think with the help of the cardiologist team, I would look into putting an impella and to tide over the crisis, because the main part in this is to maintain adequate hemodynamics, because the pressures, the supports are going up, and also end organ perfusion has to be looked into. Wherein today in the current scenario, if cost is not a factor or the availability is not a factor, and it can be considered, and simultaneously we pull out the balloon, which takes time for the crisis to tide over. And this we can either it works out as a bridge to decision or a bridge to bridge, where we can work out on these logistics. And as we see, impella can be taken off within 24 hours or can be kept up to 7 days, as few of the cardiologists do practice. And after that, we can take a call on what has exactly to be done. And if there is an associated lung factor, then definitely VA ECMO is an option which we can think of.
Because it unloads both the right ventricle as well as the left ventricle. Yeah. The only problems with the peripheral VA ECMO is afterwards, after several days or several hours, where your LV starts distending and you're having a problem, offloading the left ventricle, wherein leaving the balloon pump and putting a VA ECMO may be an option. Where you do both the things. Now, one of the questions that was just asked to me when I was giving a talk at the podium was the following. You're saying that the balloon pump in the IBP shock trial did not work, and yet we are still putting in balloon pumps. And similarly, cardiothoracic vascular surgeons, when I talk to them, when they have difficulty weaning a patient off pump, they are putting a balloon pump. Is there data in the surgical literature that the balloon pump either helps or does not help? What are your thoughts on, and are you personally, I'm going to put you on the spot, are you personally putting balloon pumps in patients that you're having difficulty weaning? And I'm not talking about advanced heart failure, I'm just talking about your low EF patients in whom you're doing complex three-vessel bypasses, etc.
Yeah, definitely as a surgeon, for me, in the availability resources, what we do practice, as in not only me, most of the surgeons in the country, wherein we use intra-aortic balloon pump, and we either place it 1 day prior or on the day of surgery before. And my strategy, what I normally follow is with the balloon pump and try to do it on beating heart revascularization we venture into, because on pump we do have a number of reports on increased incidence of stroke or CPB related other end organ damage has been reported. So definitely IVP is an option as a surgeon, and we regularly follow it.
Do we have any other options in patients who are not easy to come off of bypass? Are you thinking about putting, so for example, peripheral VA ECMO devices?
VA ECMO devices can, if we are unable to come off, it is a post-cardiotomy insult, then definitely VA ECMO has to be considered if you are to tide over the crisis in the first few days.
And do you have any difficulty in terms of maintenance of these devices in the ICU? Do you have regular, a good support staff? Because that is essential.
Yeah.
It's not a thing that, the interventional cardiologist puts in the impella and then goes home and forgets about it.
Yeah.
Similarly, a peripheral VA ECMO, these are very, very sick patients that require extremely close monitoring. So we need to have
We need
all
to have
of these
a,
support
yeah,
systems.
that's
in
definitely is a matter of concern wherein VA ECMO, the devices or the circuit what we actually plan, which is a heparin bounded circuit what we use, because the chance of less of bleeding or coagulation impairment is less. And round the clock has to be monitored, especially the ACT needs to be monitored. We maintain ACT around 200 seconds. And we do have a perfusion team which takes care of it most of the time, which are in turn monitored by our intensivist who look into it. Cardiologists take care of the impella, and since the team functions at the same platform, so definitely any intervention related complications they do handle. We do have problems associated with impella or peripheral cannulations, either it's a limb ischemia, which has to be taken care by the surgeon itself. That's how we plan and we work out.
Dr. Narsimhan, I found that continuing medical education, not just of the people who are part of the shock team, but more importantly of the nursing staff, of the technicians, the perfusionists, because these are all brand new technologies. As India is coming, these technologies are now increasingly being used in India. And I think there is a very strong need to really have a continuing education of the support staff who are really dealing with these technologies on a day-to-day basis.
Absolutely, because any technology doesn't, you need not confine this to shock team alone. Any technology, whether it's ventilator, dialysis machine, just having the equipment without personnel to monitor or know the functions of the equipment, it can be a disaster. Especially so in an acute situation like this, you put in a very expensive device, but the team in the night who is looking after doesn't know anything about the controls, you're going to be in deep trouble.
Well, thank you very much. That was a very interesting discussion. We very briefly talked about rhythm management in advanced heart failure patients. Dr. Narsimhan talked about the strategies for atrial fibrillation management, and then a little bit about the CRTP versus CRTD device in advanced heart failure patients. And then Dr. Hiremath outlined his decision-making strategies with advanced heart failure in terms of impella versus a VA ECMO. Thank you very much for your attention. We'll sign off from here.
Thank you.